It is going live, sir. Once it is live, I will start, sir. Just a second. Start, sir. Just a moment. Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. That is on very important topic. By taking any further delay, let me tell you topic for today's webinar. It is cracking CKD, MBD, expert updates and emerging insights. And for this topic, we have very eminent speaker, none other than Dr. Ratan Jha, sir. And let me share some of the achievement of sir. Sir has done DM, DNB, MD, DTCD, FISN, and senior consultant nephrologist as clinical director of nephrology, Care Hospital, Banjara Hills, Hyderabad. So by taking not much time, I would like to invite sir and hand over this session to sir. Sir, over to you, sir. You can proceed from here.
Good evening, friends. Today I am going to dwell upon a very complex topic of chronic kidney disease with mineral and bone disorder. What are the newer updates in this?
I'm still learning languages, so at the moment I can't help you with this request. So far, I don't know.
Good evening, friends. Today I am going to talk on a very complex topic of chronic kidney disease. What are the updates in this regard, and what are the emerging insights which has changed our way of thinking to manage this complex area of therapy in our day-to-day practice. So this topic is going to be covered under the following heads that we try to speak about what is this disease, what is the definition of CKD-MBD, how prevalent it is, what are the newer pathogenetic concepts, how do they present, what are the diagnostic tools, what are the treatment which were old treatment, and what are the newer drugs which have come in this area, and what are the newer concepts, future direction, and concluding this topic with the final word. We are fully aware of the fact that chronic kidney disease with mineral bone disorder is a very complex disorder of bone vascular axis interaction, where the heterotopic calcification is stimulated while the orthotopic mineralization is inhibited. That is, the bones becomes weak because of demineralization, and the vessels become more calcified because of over mineralization. That is called the bone vessel paradox. That is, the calcification occurs at the wrong site, leading to the consequences. Chronic kidney disease associated mineral bone disorder is a syndrome at the moment without any good effective therapy, and hence there's a need for new therapeutic target identification. And in this regard, one of the important things that we have found is the kidney disease is a state of chlorothodeficiency. That is a kind of a molecule which is useful for phosphaturia, and when this chlorothodeficiency happens, it may have an impact in the CKD progression. Clotho has many other kind of functions in the brain, and it is said that this is a deficiency of this molecule may have something to do with aging process. And hence, we are identifying new and newer areas which can be targeted to get to the effective therapy. The CKD-MBD is a disease which is treated by various specialties like the endocrinologist, the orthopedician, the nephrologist, and the physician. And hence, there is a need for us to understand the problem well so that we are all on the same page. The definition of chronic kidney disease earlier was like it is a systemic disorder of mineral and bone metabolism due to a chronic kidney disease manifested by either one or combination of following, that is, abnormalities of calcium, phosphorus, PTH of vitamin D metabolism that we see in the blood biochemistry, abnormalities in bone turnover, mineralization, volume, linear growth or strength that we look at the bone assessment by different tools, and the vascular and other soft tissue calcification that we try to make a diagnosis based on the radiology or the CT scan. The chronic kidney disease, we know, affects 10% of world population, and it is increasing in number throughout the world. The chronic kidney disease associated mineral and bone disease, however, affects 100% of patients with chronic kidney disease when the disease is stage 3 or beyond. That is, a patient with advanced stage of chronic kidney disease with a GFR below 60 has a kind of 100% kind of abnormalities in this regard. Though we were earlier trying to talk about CKD-MBD in 3 domains, that is the blood, the bone, and the vessel. The recent way to treat this disease has become more simplified, and we talk about 2-way approach to address the problem: the bone health and the vascular health. From the earlier 3-way that we used to talk about the bone, vessel, and the blood, because blood chemistry is common to both the organs that we talk about, the bone and the vessels. Earlier, the spectrum of bone abnormality was referred to as renal osteodystrophy, which was a kind of spectrum starting from the adenemic bone disease or osteomalacia to a mild form of hyperparathyroidism or severe form of hyperparathyroidism or osteoitis cystica with a mixture in between. And the turnover bone markers were classified as high turnover for hyperparathyroidism and low turnover, which was basically influenced by the use of extra calcium, calcitriol, and aluminum, and low turnover manifesting as either as osteomalacia or dynamic bone disease. But that was the older way to refer the renal bone health, and which is now referred by a newer nomenclature of chronic kidney disease associated osteoporosis with other abnormalities. So this is a kind of cartoon to explain how the bone health is assessed, that a normal bone has a normal bone mineral density with normal bone mass and mineralization. Osteoporosis is a situation where you have a low bone mass with a normal primary mineralization. Osteomalacia is a disorder where the bone mass may be increased with abnormal primary mineralization. Autonomic bone disease is looking like osteoporosis with low bone mass with high secondary mineralization, while the secondary hyperparathyroidism is a disease which is a disease of normal or increased bone mass with decreased secondary mineralization and increased osteoid volume. But all these disorders of bone metabolism that we see in chronic kidney disease, if we do a kind of bone mineral density, we may find that they all have a kind of values which suggest that the person is osteoporotic. That is, a bone mineral density is less than 0.625 gram per centimeter square. That is, all of them will look on the DEXA scanning to be osteoporotic, though the disease may be having a different kind of pathophysiological mechanism. And hence, the renal osteodystrophy is now categorized as CKD-related osteoporosis with other kinds of turnover markers to be assessed. So this is a new conceptual framework moving towards the personalized care in adult patients with CKD-MBD. We know that there are traditional risk factors for osteoporosis like diabetes, old age, female, etc. But the CKD-associated risk factors are usually driven through the immune system, the gut system, the uremic toxin, neurohumoral system abnormalities, and endocrine system abnormalities, which manifest as the cardiovascular disease, which is associated with CKD-related factors, or CKD-associated osteoporosis, which is a kind of different kind of osteoporosis that we see because of the abnormal seen in the biological disturbance that we talked about, the immune, gut, endocrine, neurohumoral, and uremic toxins. These kind of disorders are usually diagnosed, which are CKD-associated risk factors based on the biochemistry, imaging, pathology, and molecular assessment by different technologies. So the CVD, which is associated with CKD, is different from the cardiovascular disease, which is associated with other forms of traditional risk factor, which is the newer nomenclature of trying to categorize the risks associated with CKD-MBD. So there are changing ideas that we talked about the CKD-associated cardiovascular disease and CKD-associated osteoporosis as a part of CKD-MBD. So when you talk about CKD-associated cardiovascular disease, we mean that the CKD cardiovascular disease is caused by the non-traditional risk factors, which ultimately leads to vascular calcification in the intima, media, valvular calcification or calciphylaxis, and left ventricular hypertrophy, which is related to the arterial calcification of chronic kidney disease. So this is a different form of cardiovascular disease, which is now brought under the CKD-MBD. Earlier, renal osteodystrophy and osteoporosis were classified as two different disorders in CKD. Osteoporosis and ROD were separate entities in the earlier analysis, and diagnostic tools and therapeutic interventions were also considered to be not interchangeable. But in the recent times, this nomenclature has changed, and we talk about CKD-related osteoporosis with renal osteodystrophy as a component of it in certain percent of patients. CKD patients have a higher risk of fracture, that is 4 to 5 times compared to general population. Osteoporosis is defined as a disorder of bone that decreases bone strength, defined by bone mass and quality. Renal osteodystrophy is a global disorder of bone strength because of altered bone quality, and therapies which are protective for fracture must be personalized and based on the bone turnover and mineralization is the kind of concept that is prevailing in the recent discussions of CKD-MBD management. So now we talk about the pathophysiology of CKD-MBD that we are understanding in the recent times. We know that CKD-MBD is a disorder where there are 3 organ suffers: the vasculature, the heart, and the skeleton. So these are 3 organs which suffers, and they are because of 4 endocrine factors which are abnormal. The FGF23, that is fibroblast growth factor 23, the clotho factor or clotho deficiency, the calcitriol deficiency, and the parathyroid hormone either excess or deficiency. These are the 4 endocrine factors which ultimately lead to 3 organ dysfunctions with 2 mineral metabolism disturbances in the form of calcium and phosphorus product abnormality, and this has to be appropriately addressed. But the trials which have been done to look at the calcium phosphorus metabolism, like the landmark trial or improved CKD trial, which were basically a trial to treat hypophosphatemia, the parathyroid hormone targeted trials like EVOLVE and ADVANCE trial, the calcitriol focus trial like PRIMO trial, then vascular calcification trial like Calypso trial. All the trials were found to have a kind of no positive results to suggesting that treating these abnormalities in the late stage of CKD-MBD is not ultimately influencing the outcome so far morbidity and mortality is concerned. The sequence of this abnormality that is seen in CKD-MBD is shown in the slide. That the first abnormality in a patient of chronic kidney disease with low GFR is the rise of fibroblast growth factor 23, which is coming basically from the osteocytes. The second abnormality that is seen as the GFR falls is the vitamin D the deficiency, that is the calcitriol deficiency. The second thing that is which is basically a kind of deficiency which is because of kidney dysfunction. The 125 this hydroxy or the 25 hydroxylation vitamin D is happening at the level of the tubule in the peritubular fibroblast, and that is getting abnormal in a patient of chronic kidney disease. Second deficiency is calcitriol deficiency. The third abnormality that is seen in the biochemistry is the parathyroid hormone excess. And subsequent to that, the fourth kind of abnormality that is seen in the CKD-MBD is the rise of phosphate. So these are the 4 things which occurs one after the other, and this has to be appropriately addressed to take care of the abnormality early to get the best kind of outcome in such patient. So the stages of the pathogenesis of CKD-MBD is an early stage. We find there is a raised fibroblast growth factor 23 level are associated with reduced clotho and reducing vitamin D, which compensates for the rise of phosphorus. In the intermediate stage, that is when the GFR has fallen still higher, we find that there's a marked rise of even parathyroid hormone besides the rise in FGF23, reduced clotho and vitamin D. And PTH remains normal. But as the disease advances, this compensatory mechanism fails and the phosphorus goes up, which has to be appropriately targeted. So the marked changes of early intermediate abnormalities are seen in the late stages of kidney disease, particularly in stage 5 disease, where there is low vitamin D levels, low clotho levels, very high FGF23 levels, and high PTH levels, which will have a kind of impact in the bone health. And when these kind of abnormalities are existing in the blood, the patient can have a clinical presentation which could be quite varied. It could start from kind of abnormality with patients totally asymptomatic with very overt biochemical abnormality, or symptoms could appear late, particularly on dialysis, as the pain and stiffness in the joints because of calcification, deformities, and carpal tunnel syndrome, rickety deformity, particularly in children, with fracture risk in adults, proximal muscle weakness because of metabolic myopathy, spontaneous tendon rupture, which may not be understood to be associated with CKD-MBD, pruritus, refractory anemia, skin necrosis because of calciphylaxis, and carpal tunnel syndrome. So these are the symptomatic presentation, and the syndromic presentation could be because of bone symptoms in the form of bone pain, deformity, and carpal tunnel kind of symptom, vascular symptoms in the form of this metastatic calcification or extracellular calcification, like a tumor kind of thing, ocular calcification, calcification of joints, and a cardiovascular calcification with increased risk of cardiovascular death, and calciphylaxis. Cardiovascular disease-related presentation, which may be not understood to be linked to the CKD-MBD, could be a left ventricular hypertrophy with the risk of congestive cardiac failure with preserved ejection fraction, or in the late stages, the reduced ejection fraction. And an anemia because of bone marrow abnormality, because of bone marrow fibrosis, the EPO resistance could be seen, and all these symptoms are linked to the CKD-MBD. So a similar set of symptoms may be seen in both the low turnover bone disease and high turnover type of skeletal abnormalities, and it is difficult to distinguish the type of the bone disease based on the symptoms. And hence, the symptoms are non-specific, and it has to be investigated to come to the conclusion of what is the pathogenic cause. So this is a picture to show that what is seen is the cystic leukency in the lower part of fibula, which is looking like a brown tumor, but it is not a tumor. It is a kind of hyper osteitis fibrosa cystica localized to the femur, which was treated with drug cinacalcet, and the thing has got calcium, which has got filled up because of the treatment. Similar kind of lighting lesions seen in the tibia and in the hands are not the brown tumor, but these are the kind of lesions which are because of amyloid deposition in the bone, presenting as carpal tunnel syndrome in patients who are on long-standing dialysis. So the lighting or cystic lesions may not be always a brown tumor or tumor. It has to be appropriately looked at to understand what is the distribution, to decide what is the pathogenic mechanism. So this was an image that we published way back, 10 years back, tackling the brown frown, the brown tumor getting corrected, getting filled with because of hyperparathyroidism by the cinacalcet therapy. The cystic lesion is getting filled with the bones because of the suppression of PTH by cinacalcet. Coming to the diagnosis of CKD-MBD, therefore, we require to rely upon the biochemical tests, which mean the kidney function, alkaline phosphatase, and hemoglobin component. Look at the bone marrow disorders, which may be associated with kidney dysfunction and could be contributed by CKD-MBD. Imaging studies, particularly the DEXA scan, to look at the osteoporosis, vascular calcification assessment by looking at the coronary artery calcification scoring, the radionuclide bone study to look at the turnover of the radioactive material in the bone, biomarkers in the blood, the bone turnover markers that can be utilized could be the old biomarkers, bone markers, which may not be useful because they may be raised with a kidney failure, but the new biomarkers, which are not kidney failure markers of bone formation, like bone alkaline phosphatase, intact procollagen type 1 and propeptide, and the bone resorption marker like TRAP, tartrate resistant acid phosphatase isoform 5B, which are not influenced by renal dysfunction and hence could be reliably looked at to understand the turnover of the patient's bone. Total alkaline phosphatase at this point of time is considered as a proxy for bone-specific alkaline phosphatase. With normal levels of GGT, this can be taken as a marker of bone formation. So when we try to assess the bone strength, we look at not only the bone density that we usually look at by DEXA scan, but the turnover markers by the marker that we talked about in the blood. The microarchitecture and mineralization can be assessed by the newer tools of bone assessment that we see talk in the subsequent slide. The vascular calcification is really looked at by screening test of lateral abdominal radiograph to see the presence or absence of vascular calcification in the aorta, and the echocardiography evidence of any calcification at the level of vessels. So these are the screening tools to look at the bone as well as the vascular health. The assessment tools for the bone health is shown in the slide that there are different kind of softwares which are the tabular bone scoring software added to the recent generation DEXA scans, and the vertebral fracture assessment tool is also available in modern DEXA scan machines. The assessment of bone health is basically looking at the bone quantity that is usually done by the DEXA scan. This QCT is not done these days because of high cost and high radiation. The bone quality is really assessed by the high resolution peripheral QCT, which assesses not only the bone microarchitecture but gives a good cortical and trabecular differentiation, and it correlates with the bone histomorphometry. DEXA scan with trabecular bone scoring is another kind of assessment for bone quality because it gives us the assessment of bone microarchitecture, particularly the trabecular bone, and predict the fracture risk. And the BTMS, that is the blood bone turnover markers, which when available can distinguish the high turnover from low turnover bone region and is non-invasive. So we need to combine both the quality and quantitative markers to assess the bone in the patient of CKD-MBD to give the right kind of advice. So summarizing the idea that we talked about, that if you look at the bone disorder in CKD, there are a lot of overlaps. The CKD-MBD is a disorder of calcium, phosphorus, PTH, FGF23 in all the patients. The bone mineral density and bone mineral trabecular and cortical could be abnormal, and that is a part of osteoporosis. The turnover could be anything from low to high to normal. Mineralization could be low, normal, and volume could be also variable. When CKD-MBD is associated with CKD osteoporosis, we find that the bone mineral density is low in the trabecular bone normally, or bone mineral density cortical bone is also low. And this is a kind of similar picture that is seen in classical osteoporosis, where we have calcium, phosphorus, PTH, FGF20 normal, but the BMD in the trabecular bone is low and BMD in the cortical bone is low normal. The difference between classical osteoporosis and the CKD-associated osteoporosis is that there is more loss of the bone mineral density in cortical bone in the CKD-induced osteoporosis, in contrast to the classical non-CKD osteoporosis, where there is more bone loss in the trabecular bone. The treatment of this complex topic is summarized in the slide, that when we talk about treating CKD-MBD, we are not only focused to treating PTH hormone level, but also looking at the pathobiology. The exact or optimal PTH level in CKD stage 3 to 5 is still not clear, and it is believed that you need to look at the trend and rather than an individual value. And CKD in patients with stage 3 to 5, it is said that we should look at not only the trend but look at the values, etc., to decide in which way the things are going. 2 to 9 times the PTH level is considered to be optimal in stage 5 CKD, with a trend as a marker to decide what way to go about. The target for calcium, phosphorus, 25-hydroxy vitamin D, bone alkaline phosphatase, and vitamin D level to control PTH is still evolving. The focus on bone and vascular calcification with consequences more than the PTH. So we should focus more on bone and vascular calcification consequences more than the PTH when you're trying to treat a patient of CKD-MBD. In the KDIGO controversy conference, it was found that there are a lot of confusion about treating the osteoporosis in CKD. Few people think that we should never give calcium because the patient can have a calcification, a vascular calcification. Few people felt that the patient should get calcium sensing receptor agonist regardless of the calcium. We should avoid negative calcium balance to prevent the risk of osteoporosis, and hence we may need to have different ideas of the treatment options to be utilized by doing a bone histology, but bone biopsy is a difficult option even in the Western world, and hence there are areas which has to evolve over time, and the issues of normal reference values in different kind of areas is still not clear. Despite that ambiguity, the therapeutic arsenal in different stages of CKD is shown in the slide that we may require to give an appropriate calcium supplementation. Phosphate binders may be required, particularly non-calcium phosphate binders in late stages of CKD. Vitamin D analogs could be utilized, the old analog oral calcitriol or even the intravenous calcitriol or alpha calcidiol, or the newer vitamin D analogs like doxacalciferol, paracalcitol, or calcifediol. So these things can be appropriately utilized. Calcium sensing receptors like cinacalcet or the novel calcium mimetics like calcitide, evocalcet, etc. can be used to treat kind of hyperparathyroidism which is not getting controlled with the vitamin D analogs. The vascular calcification inhibitors, particularly vitamin K, magnesium, and sodium thiosulfate, could be utilized as appropriate. Anti-osteoporotic therapy, if needed, has to be given after controlling the calcium, phosphorus, vitamin D abnormalities. And treatment of calciphylaxis and pruritus has to be done as is appropriate based on whatever drugs which are available. One of the important areas of therapy which is evolving is how to control the vascular calcification progression in a patient of CKD. And the drugs which have been found to inhibit the vascular calcification, which are safer, are vitamin K, magnesium, SNF472, and STS. The SNF472 is a hexaphosphate phytate usually present in wheat, and it is an injectable form of drug which is found to have some kind of impact in reducing the calcification. In this regard, SGLT2 inhibitor also has been linked to inhibit vascular calcification, which should be a part of therapy in such patients who are having a kind of progressive CKD. The treatment, when you look at the treatment trends and outcome, at this point of time, the phosphate binders, the vitamin D analogs, the calcium mimetics, anemia treatment, osteoporotic treatment by different methods in different trials was found to have negative result. That is, none of these interventions have ultimately had an outcome benefit. Evidence level for in all nephrology fields in CKD-MBD are at the moment quite low. And hence it is very important that we need to make an early diagnosis and decrease the progression of CKD to have a kind of impact in the overall outcome. Despite its limitation, the PTH trends remains an important kind of marker of CKD-MBD progression to be targeted as appropriate. The modifiable risk factors in such patient is looking at the high phosphorus intake first, that is the diet has to be looked at first when the CKD-MBD is there. Hyperphosphatemia has to be treated with after the diet management with phosphate binders. We have to look at the vitamin D deficiency, both the nutritional vitamin D deficiency and the calcitriol deficiency, and by giving appropriate drug therapy to lower the PTH. And hypocalcemia has to be targeted last once all these factors are taken care. So when we talk about drug options in bone health, there are two types of options which are available: anti-resorptive therapies or osteoanabolic therapies. The anti-resorptive therapies are basically biphosphonate and denosumab, which are useful in high turnover bone disease patients, while osteoanabolic therapy like teriparatide and abaloparatide might be better therapeutic options to improve the bone health recipients in low turnover bone disease. But these therapies are given only after excluding the uh, the CKD-MBD component which is associated with either calcium, phosphorus, or PTA deficiency. That is, high turnover therapies are to be adopted after treating the hyperparathyroidism, while low turnover therapy has to be adopted after treating the osteomalacia with the drugs that we talked about, the options, the osteoanabolic versus the anti-resorptives. So the holistic approach to CKD-MBD not only focuses on drugs, but it looks at the diet, that what kind of calcium and phosphorus you are taking, what is the type of dialysis therapy that you are giving, are you giving adequate dialysis therapy or not, what is happening to the vascular calcification, and what are the things that we can give to control the vascular calcification, and how to take care of CKD-associated osteoporosis related fragility fractures, which may be associated with increased mortality. And in this regard, the areas of diet, drug, dialysis, calcification, and osteopathic therapy will have a kind of basis to choose based on the patient's preference for health. So, in a patient of chronic kidney disease with osteoporosis and renal osteolysis dystrophy component, the base of pyramid is that you should have a balanced diet, stop smoking, limit alcohol, start having a weight bearing exercise so that the bones become strong, and measures should be there to prevent falls and fractures. The pharmacological therapy will be in the form of managing the CKD-MBD with appropriate calcium, appropriate phosphate loading therapy, vitamin D, and vitamin D receptor analogs and calcium ion mimetics in majority of the patients. Few patients will require an anti-resorptive therapy in the form of biphosphonate, denosumab, or osteoanabolic steroid like teriparatide, abaloparatide, or romosumab, and parathyroidectomy will require a small number of patients. The newer biomarkers in patients of CKD-MBD which are emerging are the sclerostin level, which is said to be a useful biomarker to be utilized in making a diagnosis of CKD-MBD, and this is a marker which is targeted with anti-sclerostin therapy. GASI protein particles are also emerging a new biological marker. CPP consists of phosphate, calcium, and some protein, with phosphate being the major contributor to level and biological activity. A CPP will be a marker to look at the turnover. So the newer concepts which can lead to a future direction of treatment change is the looking at the FGF and Klotho interaction. FGF, that is fibroblast growth factor inhibitors, could be useful whenever it is available, and the Klotho supplementation, because FGF interacts to the Klotho, and Klotho deficiency is to be a marker of CKD-MBD, and hence this could be a way to look at the future. Sclerostin pathway and the WNT pathway modulation by appropriate drug can lead to increased kind of bone formation. Osteocyte biology unraveling is also happening at a very fast level, and that may help us to get certain drugs which can be targeted to a specific patient. Post-transplant mineral and bone disease, which is basically in osteoporosis, has to be addressed in a separate way. And the future directions will be novel targets, improved biomarkers, and patient education. So this is a slide to show that when the osteocyte has a dysfunction, it can be targeted at the level of this primary mineralization or at the level of secondary mineralization by drugs which will be acting at FGF23, RAN, or sclerostin level. The bone formation and bone inhibition has been now understood by understanding the molecular pathways of WN2 beta catenin pathways, and they are certain drug molecules just targeting the pathways at a very molecular level to get to the goal. So to conclude, chronic kidney disease associated mineral bone disease is to be treated holistically with evolving wisdom. CKD-related cardiovascular disease and osteoporosis need to be recognized as a new clinical syndrome to target. Acidosis has to be corrected by focusing the bicarbonate level to be around 24. Vitamin D treatment with cholecalciferol should be a routine to treat to target of more than 13 child and possibly in adults. Calcitriol is to be utilized only for controlling hyperparathyroidism stage 5 CKD, and near D vitamin D steroids like doxycalciferol has been found to be no good in this regard and no different from calcitriol. Cinacalcet, etanercept can be utilized control the hyperparathyroidism once the vitamin D as well as the calcium therapy has been appropriately used. Newer drugs like vitamin K2 and magnesium oxide may be of practical use to treat patients of osteoporosis. Osteoporotic treatment is to be instituted based on the DEXA scan, PRAX coding, and biomarkers after taking care of the calcium, phosphorus, PTH, and vitamin D metabolism. Exercise has been found to have a favorable effect on bone turnover because it downregulates the inhibitor of WNT pathway like sclerostin, and hence we have to advise patients to undertake exercise that is appropriate for their health. And the final comment is that as a nephrologist, when we look at the CKD-MBD treatment over time in the last 3 decades, we are not dwelling on the regrets that we are not having any good drug, which is ultimately having an impact on outcome, but we're evolving with time. Now there are more diagnostic and therapeutic options, and he may have a better kind of therapeutic approach in future. We need still more studies to show positive results with the intervention that we do. In the meantime, the lives of patients can improve significantly with the holistic care as we await more trials and drugs. Thank you. Back to the organizers for any questions if there are any.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice also. Sir, we have received some question. With all your permission, shall we take these questions one by one?
Yes.
First question I can see from Dr. Subramaniam. He is asking, how do you approach the challenges of balancing phosphate control while minimizing their risk of vascular calcification?
The management of the phosphate control is first management is diet. That person has to have a dietary restriction. One has to understand which are the items that are having high in phosphate, particularly in stage 5 kidney disease. That is a problem that is there. And we know that the phosphates which are high in amount are in the milk products as well as the products which are available outside as fast food, which contain very high amount of phosphorus is absorbed. We tell the patient when they are having hyperphosphatemia and let's say kidney disease to restrict these kind of food when they are getting treated on dialysis, particularly the fast food because which is having a very high amount of phosphorus, and milk has to be taken, but in an amount which is which can be managed by the phosphate binders as well as the dialysis.
Thank you so much, sir, for sharing your expertise on that question. Moving forward, we have another question, sir. What is your protocol for initiating and adjusting vitamin D analogs in CKD-MRD, and how do you monitor for over suppression of PTH?
This is a very important question that we find that when the patients have CKD-MBD are universally having a very low vitamin D level. So we find that this is the thing that is to be always supplemented in our patients. The vitamin D, that is the nutritional vitamin D, that is not the activated form of vitamin D. So that the first thing is to give the cholecalciferol that we give for the general masses that is there. And once that is corrected, then we look at the treatment of the vitamin D deficiency or calcitriol by giving a calcitriol supplement, either oral or IV, to lower the PTH level. This approach of using calcitriol should not be used in every patient. We have to look at the vitamin D and PTH level to decide whether to give vitamin D or whether to give calcitriol. And if PTH is high, if calcium and phosphorus are in the right range, then we give a calcitriol to control the PTH. A routine kind of prescription of calcitriol that we see many times is harmful because it makes the patient this PTH deficit of PTH is suppressed, which increases the risk of autonomic bone disease and risk of fracture. So there is nothing called routine therapy for every patient. We have to look at vitamin D level, look at the PTH level, look at the background kind of disease like diabetes, young age, CKD of CIN type, which are having a different kind of clinical profile to decide this is high turnover or low turnover. High turnover patient have to be given PTH loading therapies after vitamin D has been deficiency has been taken care of. Routine PTH supplementation like in diabetes should not be done because most of the diabetic patients are having a low turnover bone density, where suppression will lead to a kind of vascular calcification as well as increased risk of fracture.
Thank you so much, sir, for sharing your expertise on that question. Sir, one feedback from Dr. Subramaniam. Wonderful presentation and thanks for responding my answer.
Thank you.
Questions is written, and sir, as I can see, there is no more further questions, sir. As there is no more question, with all your permission, shall we conclude this session for today?
Yes, thank you.
Yeah, welcome, sir, and we would like to see you in future also with different topics, sir. Till then, take care.